I'm going to do mostly the cases to show you how I treat bone defects. I think bone defects is one of the most interesting parts of our job to treat. The causes of bone loss in kids can be a little bit different than in adults. I also have an adult practice. I would say the top three is trauma, infection, and tumor. The options of how you treat this. In my opinion, there's really only 4 good options in kids: the masculine, vascularized fibula, cadaveric bone graft, and bone transport. And I have a preference, which I will show you. There's different advantages and disadvantages to each, but I'm going to show you that in the cases. There are other options in adults, but in kids, endoprosthesis or titanium cages is really not a good option. If anybody doesn't know what PAPST is, I just want to make sure you do before we show the cases. So it's a plate-assisted bone segmental transport. Okay, and I'm going to show you a case like that. So case 1. 7-year-old boy was pinned between the car and the garage door after his brother decided to repark the car because his mother didn't do it properly. And he came into the emergency room with bilateral open injuries. This is the extent of the soft tissue injury, which you can see. And this is what the scan and x-rays look like. So bad open injuries, bilateral open segmental femur fractures. Options for treatment, I think most people would do damage control orthopedics. Some people, like Nando Ferreira, think that the best X-fix to put on is a circular X-fix. I tend to agree. So this is what I did for this patient. It's a trauma X-fix, but something that he will eventually be able to walk on. Same thing on the other side. And we left the piece in the middle because you never know. For now, we closed everything and we went in for a second look to see. At the end of the case, we lifted the leg and there was a, I guess, fracture that we didn't see in the tibia. So we treated that at 2 o'clock in the morning with a cast and came back to put an X-fix later. So eventually his soft tissue injuries healed with skin grafts only, and he started walking with his X-fixes. And the right side healed. Okay, great. The left side, this part healed. Only the distal part didn't heal. So that part in the middle is alive. And so what would be the best option now for, looks like a pretty small bone loss? You can do compression. Maybe you could do a nail in this patient. But I think the right answer here was a bone graft. And so we went in to bone graft him. And amazingly, young patients heal well. So just a bone graft was enough to heal him. He continued to walk and load the bone graft with the X-fix. Eventually healed, except he has a limb length discrepancy. So always make sure that you follow them for alignment and limb length discrepancy. What did we learn about this case? You don't throw the bone out yet in children, okay? You never know. In children, you never know. In adults, forget it, put it in the garbage. The healing potential is incredible. And sometimes, when you're lucky, bone graft is enough. All right, case 2. 11-year-old girl. She's otherwise healthy, shows up to the emergency room, fever, vomiting, pain in her ankle times 12 hours, cannot walk on the ankle. Those were her x-rays. They sent her home. There was nothing to see. Came back, did more investigations because she was still having fever, returned 3 days later with more pain. Her ESR was 47, her CRP was 211, and the bone scan showed an osteomyelitis. We were still doing bone scans then. The blood culture came back. She had MSSA. Antibiotics were started and then changed accordingly. She had 6 days of IV antibiotics, no improvement. Still having fevers. So they requested an MRI, and you can see the pus in the canal. And then they took her into the operating room, irrigation, debridement, lavage. So they tried, the debridement was done several times. She continued to have pus coming out of the wound. 1 week later, the pus again, took her back to the OR. It's been like 4 weeks now. She has a chronic draining sinus. Continued to have low-grade fever. The CRP came down. And you can see this x-ray, and something's not right here. Even on this projection, you can see that something's not right with this part of the bone. So what happened? The bone died. It died from the pressure. It's like an intramedullary compartment syndrome. So now we have to deal with the dead bone. So you cannot leave dead bone because the infection will never go away. So first we put in beads. And then we decided to take some time to decide how we were going to treat this. The 2 good options here is to get rid of the dead bone. You can see on a picture which part of the bone is dead. This is a great trick. If you're not sure which bone is dead, you take a picture. And the reflection of the light will show you the difference between the dead bone and the alive bone. So this was dead. We took it out. So about 5 centimeters worth. So how do we manage a 5 centimeter bone defect? I think masculine is a good option. Bone transport is probably a better option, but the patient didn't want the cosmetic effect of a bone transport. So we put in the cement spacer. put her into a frame, and then got some bone graft, filled it up with bone graft, and she healed. Bravo. I thought I was great. Wow, the Mascalet really works. Mistake. What was the mistake? Anybody? Yeah. I let her walk. No, she was fine. Yes, internal fixation. Because what happens with Mascalet? It's not a live bone, it's dead bone. And until it revascularizes, she had a stress fracture, and then went on to a non-union, and then went on to deform. So she has a deformity now in the sagittal plane. This is classic Mascalet problems. So I fixed her with distraction of the non-union because she had the bone to make the non-union go away. It's a hypertrophic non-union. So we distracted it, corrected the deformity. I didn't put anything inside because now it healed. But that is the message is Mascalet is high risk if you don't put internal fixation. Case 3. 18-year-old man had an accident with a round saw. It cut open the leg, cut out the bone right by itself. Already we had a gap. He was treated at an outside hospital, put in a standard X-fix, and they put the bone cement in to see if they were going to do a Mascalet, and then sent him to me. I told the patient, Mascalet is okay, but we need to put internal fixation, or we do a bone transport. So he chose bone transport. I think that this is a much more reliable thing. He also had a soft tissue gap, which means I could do a bone transport, close the soft tissue gap with the bone, and not need a flap. And this is a pretty straightforward case for me. One of the learning points here is that you don't always need to bone graft the docking site. If you compress it enough, it'll often heal. So in this case, I did not have to go back to bone graft it, and he went on to heal. All right, 2 last cases. So, 14-year-old boy. You have Amish? No, 2. I have time. I'm looking at the clock. There's a 14-year-old boy. He's Amish. A horse and buggy accident, if that could be. Horse and buggy. Not a car accident, horse and buggy accident. He fell through the platform. The wheel caught his leg. Segmental bone loss, bad soft tissue injury. So what are the options here? Well, the fibula is broken here. That's a good thing. I'm happy the fibula is broken. So this patient is challenging because they refused the flap. They made their own special honey-based ointment, put it all over the leg, and by some miracle, this actually worked. And I did a compression distraction. So this is a nice case for acute shortening, so that you can get the leg and the soft tissue flap to close faster. So we did acute and a little bit of gradual just to get it compressed, and then distraction at the proximal part to get the length back. And he went on to heal. And the lesson here is if you do the compression faster than the distraction, you can get the docking site to heal a lot more quickly. But the caveat is the fibula has to be broken also. Okay, last case, Mark. That's it. It's an amazing case. 23-year-old girl. She currently has a broken prosthesis, okay? She had a previous osteosarcoma to her right femur at 11 years old. She was treated with chemo and resection, no radiation. And the reconstruction, you can see, was initially done. They took one fibula, then they took the other fibula, and because the first time it didn't work. Again, after they took both fibulas and it didn't work, they did a trial with a cadaveric bone with plate and screws and lots of cerclage. When you see this many cerclage wires, you know there's a problem. She broke again. They did it again. She broke again. Then they did it again, and she broke again. And then they decided, okay, screw this, we're going to do a metal implant. So they did a replacement with the metal implant. You can see the large limb length discrepancy here. She failed after less than 3 years, and she was told that the failure was because of the limb length discrepancy. So they changed it out. Initially had trouble. They took her, they put cement, they took her back, they fixed it again, and they shortened the other leg by 4 centimeters. And this is how she presents to me. Again, she failed less than 2 years later. This lady has had now over 16 surgeries. She's 23. So now what are the options? So they told her the next thing is total femur replacement at 23 years old. So I don't think that's a good idea. I wanted to do the removal of the implant, but my colleague had already scheduled her for removal. So I told him, all I need you to do is take it out. Don't break the top and don't break the bottom. I need it. And look what they did. When you see the cerclage, it's a bad sign. It's always a bad sign, the cerclage. So they did a vertical osteotomy to be able to remove all the cement. And they did the same thing distally, killed me. And this is what they left me. They sent her to me like this after. So now, what's the answer? How do we fix this? Mark. You ask me, now I ask you. Okay. So this is very challenging, obviously, but the best solution for this patient is to have her own vascularized bone because they tried everything else, right? So bone transport. Bone transport, in my opinion, is the most reliable thing you can do. So this was plate-assisted bone segmental transport, one nail, one motor, taking bone from both directions. I had a little problem here along the way because they had split my bone, so this split eventually, even though I put a little plate, so I stopped the lengthening proximally, continued distally, eventually switched out the nail to be able to continue here. And this is where she is today. So she has about a 2 centimeter limb-length discrepancy. She's healing slowly. Here I'm happy. I have Regenerate. I think it's going to heal. Here I'm a little bit worried. I think she might need another procedure eventually. We're not done yet. But at least we're not starting from like a half-empty femur. We have somewhere to go, even though she probably is going to need a few more procedures. So what did we learn? Vascularized fibular grafts can be problematic. Bulk allograft takes super long to heal because they need to revascularize and they're high-risk fracture. Usually the bulk allograft will heal on one side, but not both. Endoprosthetics for pediatrics is a terrible solution. Take out your own cement. Next time I won't let them do it. And nothing is better than your own vascularized bone. Thank you very much.